The scan is already analyzed before the specialist finishes reviewing it. A probability score appears. Malignant probability, 87%. Confidence, high. The radiologist studies the image. They hesitate, not because they disagree completely, but because their interpretation is slightly different. The system says act, their instinct says monitor, and this is the new pressure point. If the system is statistically safer, overriding it is no longer neutral. It's risk. That's the threshold we've crossed. Not when AI became impressive, when it became safer than the expert. There was a clear hierarchy. A machine could assist. A machine could display data. A machine could enhance imaging. But the doctor made the call. In radiology, a specialist would examine a scan, compare it with experience, consider patient history, and issue a diagnosis. In oncology, treatment decisions were debated in tumor boards, human beings arguing over risk. If something went wrong, responsibility landed somewhere visible. A name, a judgment, a rationale. Expertise meant living with uncertainty. Two experienced doctors might disagree. That wasn't a flaw. It was the cost of dealing with complex bodies. Medicine was built on trained perception, years of pattern recognition refined through exposure. That perception wasn't just data processing. It included context, fatigue in the patient, tone of voice, family history mentioned casually, a feeling something doesn't align. Judgment carried weight because it carried ownership. The doctor wasn't just interpreting images. They were accountable for consequences. That was the baseline, and patients felt that baseline too. When a doctor said, "This is my call," you knew someone was standing behind the decision. Uncertainty was uncomfortable, but it was human. Responsibility had a face. That visibility mattered more than accuracy statistics ever could. Then the benchmarks arrived. In controlled trials, convolutional neural networks trained on thousands, sometimes millions, of images began matching or exceeding specialist accuracy in specific domains. Breast cancer detection, lung nodule classification, diabetic retinopathy screening. Peer-reviewed studies showed measurable gains in sensitivity and reduced false negatives. In some deployments, AI systems detected patterns earlier than human reviewers. This matters because medicine measures safety statistically. If a system reduces missed tumors by even a few percentage points across millions of scans, that translates to lives. Hospitals and insurers notice numbers like that. Once a model consistently performs above the median specialist on specific tasks, something shifts. The conversation changes from, "Is it impressive?" to, "Why wouldn't we use it?" Radiologists begin reading scans alongside algorithmic heat maps. Regions of concern are highlighted before human eyes settle. Risk percentages appear in the interface. The system doesn't replace the doctor, it frames the image, and framing shapes interpretation. When a highlighted region glows red, ignoring it requires conscious resistance, not because the doctor is less skilled, because the system carries statistical backing, and statistics are defensible. This is the quiet destabilization. The model doesn't have to be perfect, it only has to be safer on average. Hospitals don't evaluate safety emotionally. They evaluate it at scale. Across thousands of scans, across annual mortality reports, across litigation risk. When aggregate performance improves, institutions adapt, even if individual clinicians feel the ground shifting under their authority. The threshold isn't when AI outperforms occasionally, it's when defying it becomes professionally dangerous. Imagine this scenario. A scan shows a faint irregularity. The AI flags high malignancy probability. The radiologist believes it's benign. They override the alert. Months later, the patient returns with confirmed cancer. The case is reviewed. The audit shows The model flagged risk. The clinician overrode it. Even if the reasoning was sound at the time, the documentation changes the story. The question shifts. Not was this complex, but why was the safer statistical option ignored? This is how performance becomes pressure. Following the system is shielded. Overriding it is exposed. No one mandates blind compliance, but behavior adapts. Doctors begin deferring more often in borderline cases, not out of incompetence, out of liability awareness. Once that pattern stabilizes, expertise subtly changes form. The specialist becomes a validator, a supervisor of outputs, not the origin of judgment. And this is the professional breach. When performance wins consistently enough, authority follows. Not emotionally, operationally. After that threshold, medicine still looks human. Doctors still explain results. Patients still ask questions. Treatment plans are still discussed, but beneath the conversation, something structural has shifted. The safest position is alignment with the system. The riskiest position is intuition without algorithmic backing. Young clinicians train in environments where algorithmic scores are standard. They learn where alerts appear. They learn what probability ranges trigger escalation. They learn what documentation protects them. Over time, the mental model changes. Instead of asking, "What do I think this is?" the internal framing becomes, "Does my interpretation align with the model?" Expertise narrows toward supervision. The doctor becomes the final signature. That signature still matters, but differently. It confirms alignment. It verifies compliance. It ensures documentation is complete. What it rarely does anymore is initiate the primary direction of the decision. The initiative increasingly comes from the system, and because the system defines the boundaries of acceptable judgment, the signature confirms direction rather than sets it. Patients rarely see this layer. They see competence, they see compassion, they see care. But if two options exist, one statistically safer according to the model and one grounded in human instinct, the safer metric carries institutional weight. This isn't science fiction, it's workflow logic. Hospitals optimize for reduced harm. Insurers optimize for defensibility. Regulators optimize for consistency. When the numbers favor the system, resisting it requires courage with professional consequences. That's the new terrain. Not doctors disappearing, doctors operating inside statistical guardrails defined by machines. And once expertise becomes supervisory instead of primary, authority shifts permanently, because reverting to intuition alone no longer looks brave, it looks negligent. If this unsettled you, that's because it should. The most disruptive technologies don't remove experts. They make ignoring them unsafe. Tap like if this surfaced something you've already sensed but couldn't articulate. Subscribe to become part of the Unlocked, where we examine how intelligence, performance, and power quietly reshape what it means to be human. And if someone you know still believes expertise is untouchable, share this with them. Because the most irreversible change isn't that AI can diagnose disease, it's that once it becomes safer on paper, human judgment stops being the final word. Because the future isn't coming, it's already here.